this is the case, again, of a fairly young woman. She's 31 years old, and she works as a molecular biologist, and somehow she was diagnosed with a facial dermatologic problem, and when she came in, she got the diagnosis of SLE and dermatomyositis in form of a so-called overlap syndrome, which means she has both forms, and she had fairly high Rho antibodies. The Rho antibodies were excessively high. I can't remember how high they actually were, but they were significantly elevated. She had normal renal function, and she reported that she always wanted to have a child, and just I think 2 or 3 months before she was diagnosed with the diagnosis of SLE, she had an abortus. I think it was in the 23rd week or so. And well, she was kind of course, surprised to have the diagnosis and not very happy, as you can imagine. But further evaluation, showed that when she was admitted, that everything was fine, fairly okay. So she had a normal ECG. I would say you all recognize that nothing spectacular is seen here. And she also had, aside from the fact that she had, of course, the autoimmune disease, no other abnormalities that would point to any other disease. She said she was a bit short of breath once in a while, but nothing that would really make you think that anything was wrong, from the cardiovascular system. Okay, so this was what happened, and then she was sent home, and they thought, okay, the best therapy for the SLE would be to give her immune globulins. Now, I'm not a dermatologist, and I have no idea how to treat this disease to the best, but that is what was recommended to her, and she was admitted to the hospital again to have immune globulin therapy. And I forgot to tell you something. She did also have an echocardiogram initially because of the shortness of breath, which was done by someone who was very experienced and whom I personally know and whom I personally trust. And here you can see the report, which is just a screenshot of the report. And what you see is that she has a normal left ventricle with normal global function, no wall motion abnormalities, normal valves, and she has nothing which is in any way related to a pathology, a normal pulmonary artery pressure of 22, and I just want to point you to the fact that she has normal septal size. Okay, and then she was admitted with this ECG. Now, isn't this a surprise? I guess all of you, will probably recognize what is wrong here. We have, deep negative T waves in 1, 2, in AVF. This is something wrong here, I guess. And we also have negative T waves here in the left precordial leads. And if you look at this, this also looks as if she has left ventricular hypertrophy. Okay, so, what is going on here? What is her problem? I think this is something that I would like to ask you, but only after I show you the echocardiogram, because this again was a very big surprise. Okay. Okay, this is the peristernal long axis view. She had a fairly high heart rate of somewhere of 98 to 100. She was very excited because she was very nervous during the exam. She said she normally had a heart rate which was significantly lower, but this is the echocardiogram. Okay, remember the case I showed you before? When you looked at the myocardium, it looked completely different than this one here. Okay, I'll just show you a few more views. We measured the septum here at the base, which was 13. Yeah. This is the short axis view. Let me just measure the septum again. Okay. Okay, this is 13 here. Okay. Now remember, this is a young woman with no history of arterial hypertension, and blood pressure values were completely normal. As a matter of fact, they were actually subnormal. She had values somewhere in the range of maybe even 100 to 65. Okay, this is now the short axis view. Look at the papillary muscle. Look how thick the papillary muscle here is. She has a bit of pericardial effusion. Okay. And this is here now the 4-chamber view. Okay. How many of you think that left ventricular function is normal in this patient? Well, if you look at the ejection fraction, we calculate an ejection fraction of somewhere in the range of even 67, close to 70%. Yeah. But does she really have normal left ventricular function? You know, I keep on asking this question because I'm not a believer in ejection fraction. I'm kind of a lone rider here because everybody talks about ejection fraction being so important. Yes, it is, but I think in many, many cases you can really be fooled by just looking at ejection fraction, and this is one of the cases. I'll come back to that later, but let me just ask the question now first because I want to know what is wrong here. Okay, why don't we send the poll out? Do you think the patient has infiltrative heart disease? Or maybe she does have hypertension, we simply do not know it? Is this some form of congenital defect that the patient has? Or maybe it's hypertrophic obstructive cardiomyopathy? Or maybe it's hypertrophic non-obstructive cardiomyopathy? Okay? I'll give you some time to think about it. Okay, lots of you have already entered a diagnosis. I think, you know, the tricky thing here, or at least the big question here is, why the hell does someone who has a normal ECG 3 weeks ago all of a sudden develop negative T waves and a myocardium which is significantly thickened and obviously looks as if it could be either hypertensive heart disease or hypertrophic cardiomyopathy. Okay, let's close the poll. Well, 2/3 actually think it's infiltrative heart disease, and 13% think it's hypertrophic obstructive heart disease, while, non-obstructive cardiomyopathy, and 11 think it's just obstructive cardiomyopathy. Well, let me just clarify this first, if it could be obstructive or not. And this is the image that you should be looking at. This is an apical long axis view. If you have obstruction, what you would see here is you would see a so-called SAM, which means that the anterior leaflet somehow moves towards the septum and thereby obstructs the outflow tract. You can look at that also with color Doppler, and here you can see the color Doppler, and there's normal flow. So there is no obstruction here. So if it is hypertrophic cardiomyopathy, in reality, it is certainly non-obstructive. Okay, so you can also use the continuous wave Doppler signals to see if there's elevated flow, and there was no elevated flow. There's no other pathology. The valves are completely okay, right? And coming back to the question of left ventricular function, remember, if you look at radial function, let me go back. Wait, I have so many things I want to tell you at the same time. The first thing I'll just turn to is how large is left ventricular mass. This is the mass calculation of the left ventricle. Normally, you would have maybe 110, maybe 120 grams mass of the left ventricle. In this case, it's 165, which is significantly increased. So no question, there is hypertrophy. But now coming back to radial function, if you look at radial function, it's completely normal. The ventricle is really doing fine, and if you just solely base your estimation of left ventricular function on radial function, you'll be off in this case. Because if we perform, again, a speckle tracking analysis, looking at longitudinal function, you will see this is not a normal ventricle. We have lots of regions which have completely decreased longitudinal global contraction, longitudinal regional contraction, and the global peak longitudinal function is only 11.5. So the cutoff value is somewhere in the range of maybe 14 or 15. Even 15 would be kind of, I would say, in the outer limits of normal. And with 11.5, there is no question, global longitudinal function is reduced, which can also be appreciated if you simply look at the left ventricle, right? Here is the left ventricle again, and look at how the ventricle moves. It's just moving inward. It's not really changing its length. And if I just leave the cursor right here, I hope you see that, at the mitral valve annulus, we see that the annulus is not moving at all. It's just stable. This is a sign that longitudinal function is severely decreased. Okay, but coming back to what this patient has. Well, to tell you the truth, I do not know myself. I think one thing, like I said, is very strange that all of a sudden she develops left ventricular hypertrophy so quickly. This would speak in favor of some other disease, maybe that there is something related to the autoimmune disorder, which lets the myocardium simply swell and you know, have the configuration it has now. Of course, the question would be if she still has overt left ventricular hypertrophy in hypertrophic cardiomyopathy, and that that was not present before, that it developed so quickly, and that maybe the echo was off somehow when they measured the thickness of the septum. So what I'm after now is I'm after the old echocardiogram to really compare if everything was really normal at that time. And the third thing, which is interesting, is that she has an abortus. Remember, she lost her child, I think, in the 23rd week. And what they did was they had an autopsy done of the child to figure out why the child was lost. Obviously, that was an interesting finding because she wanted to know if she could have a child again and if it was somehow related to a congenital defect or if it was maybe related to the autoimmune disease. And the autopsy was performed. Unfortunately, the child was pretty... I think macerated is the right word, and the heart was found, the endocardium was infiltrated by some form of infection or by some form of inflammation. That is what the histology report reported of the fetus, and they thought it was more related to the SLE, and you know, nobody thought about hypertrophic cardiomyopathy at that point anyway. But what is the consequence in this patient? Well, the first consequence is that we'll have to investigate her further for hypertrophic cardiomyopathy. We'll have to look at her family and see if anybody else has hypertrophic cardiomyopathy. We will also perform a 24-hour Holter ECG, of course, and I also think that she needs a genetic testing to figure out if maybe this is hypertrophic cardiomyopathy. Of course, that does not mean that we are sensitive enough to always detect hypertrophic cardiomyopathy because we're not able to really analyze all forms of the disease so far. And of course, we'll do follow-up studies, especially after she has her antibody treatment, to see if this somehow goes back or not, if this reverses. And finally, just one thing that I found on the internet, there is a publication, or there are publications which do show that there is an association between diseases like SLE and hypertrophic cardiomyopathy, simply because it seems to be related to this very similar gene. There is a defect which can affect a gene that somehow encodes for both SLE, autoimmune disease, and hypertrophic cardiomyopathy. So an exciting case, but again, a case where, you know, I simply do not know the answer. You know, what we show here is we show more kind of Dr. House style cases, meaning that not everything always goes right and not everything is always clear at the end. But in the end effect, I think the main point is that we want to show you the real world, and we want to show you how echocardiography can obviously provide important information, but how sometimes it just raises new questions which we are not able to answer or which need some time to be answered. Okay, so this was the case of this young lady.